Norwalk Hospital is the first hospital in New England and only the 6th hospital in the United States to be nationally recognized for its leadership in the fight against lung cancer.
And we'll tell you what that means on this week's Health Talk. We're up next.
I'm Dr. Eric Mazur.
And I'm Dr. Vicki Sneakat. Today we're going to talk about lung cancer. Joining us to discuss this important topic is Dr. Stephen Winter, Norwalk Hospital's Chief of Pulmonary and Critical Care Medicine. Welcome, Steve.
Welcome back to Health Talk. It's always good to have you.
Thank you.
So, Steve, tell us a little bit about the magnitude of the problem with lung cancer. It's one that I know strikes fear in my heart and everybody else's heart.
Well, I think what most people don't realize, it's a leading cause of death from cancer in the United States. 250,000 Americans got lung cancer last year. Almost 170,000 of them died from lung cancer. Twice as many women die from lung cancer as breast cancer. It's a big deal. It's a huge problem, and it's not widely publicized the way other kinds of cancer have been.
And while it's related to smoking, there are people who get lung cancer without smoking. Not true?
More than ever before, 19% of women who get lung cancer have never smoked, and about 10% of men. Overwhelmingly, the majority of people who get lung cancer have been smoking or have been exposed to something like radioactivity or something that may have caused or been causative. But a striking number of people, especially women, who are getting cancer now have been lifetime non-smokers.
And that's really frightening because when you can tie it to a known risk factor, you can actually, give some steps to mitigate or prevent in others. But when you really have cases that are popping up idiopathically, as we say in medicine, it makes it a lot more challenging.
Yes.
Are there other known risk factors other than smoking, which is the most obvious one?
Yes, there are certain things like radon, high exposure in your basement that's not abated can increase the risk. A very big factor is asbestos. If you've had exposure to asbestos, a lot of men through many years past working on brake linings for cars or insulation.
Right. Asbestos and mesothelioma because of all the lawyers who were advertising for that on TV. Right. But lung cancer is really much more common than mesothelioma as an outcome of asbestos exposure.
Far more, and if you were exposed to asbestos, you have about a 4 to 5 times increased risk of lung cancer. If you smoked and had exposure, the risk is about 20 times greater. And lung cancer is far, far more common from asbestos exposure than mesothelioma.
What are the symptoms that patients present with?
The most common symptom is a cough that won't go away, occasionally coughing up blood, things like weight loss, or just loss of energy occurring over time are also things that can occur.
But those are usually later findings,
They
correct?
are, and the majority of patients are diagnosed based on an X-ray abnormality. And later we'll be talking about lung cancer screening, and this is really, screening is for patients who have no symptoms. And overwhelmingly the most common thing we find in patients who are diagnosed with lung cancer is that they present with no symptoms at all.
And that, unfortunately, it used to be that with lung cancer, as you said, most patients were diagnosed late, and as a result, most patients who were diagnosed with lung cancer died of lung cancer.
Right.
And there have really been some breakthroughs in both the diagnosis and the treatment of lung cancer in the past decade. So maybe you could say a few words about those.
I think it's extraordinary. Lung cancer has evolved on so many different fronts. The screening, the finding patients with lung cancer has just exploded. The way that we diagnose it, we use very minimally invasive techniques that require not even being in the hospital. New techniques using ultrasound and special kinds of scopes. We use genetic testing to profile patients and find new treatments and a number of new chemotherapy agents that don't cause the loss of hair or nausea. They're simply pills that are easy to take and very effective.
Pills,
Right, and one of the things we found is that this population of patients, especially women who have never smoked, often have genetic abnormalities that we can find in the cancer tissue that allow us to use highly targeted and very effective therapy. At every point, the surgery for cancer to remove the cancerous tissue has evolved dramatically, and one of our surgeons will be talking about that later in this session. It's just been an explosion of innovation, and I think in the next decade we'll see that much more as the importance of lung cancer has really come to the forefront.
Would you say that there are significant differences in the response to treatment between those patients who have had a smoking history versus those who might have more of a genetic predisposition? Can you comment on that a little bit?
Yeah. Well, we talk about genetic mutations that are associated with certain tumor types, and there are targeted or actionable mutations, and those are ones that have a specific chemotherapy that's been developed for that mutation and for that mutation only. And we have 2 clear ones that have been FDA approved so far, and a lot more that are out there just being tested. And patients who have a specific genetic mutation in their lung cancer respond dramatically well to these new cancer therapies.
Yeah, good point. This is very different than your father's chemotherapy.
Very different.
The chemotherapy that I used to administer largely targeted any cells that were dividing. So it
Right.
poisoned the DNA, it poisoned the protein synthesis pathway, and you tried to titrate the dose so it killed more cancer cells than normal cells, but they had a lot of side effects, and they were dangerous to use because they damaged the blood and the linings of the mouth and the stomach. What we're really talking about here are being able to profile cancers so that we know the signals within the cell that are causing that cell to grow, and giving drugs that specifically block those signals in certain instances. So they have much less toxicity, and although we call it chemotherapy, it really is genetically targeted therapy.
Yeah. And I think we're at the very beginning of a profound change in all of this. And in fact, we may stop within a decade. We'll stop talking about lung cancer and breast cancer and colon cancer, and it'll be out translocation positive cancer and ROS positive cancer, that the mutations define the cancer much more than the tissue that it arises in. And I think that's very much right on the horizon. This is something we're looking at in the near future.
Now, is chemotherapy, it's still surgical management with chemotherapy as an adjunct, or are there certain lung cancers that you would treat just with chemotherapy?
Well, when a lung cancer has spread, then the only treatment is chemotherapy and radiation therapy.
Okay.
But if we're able to find cancers in an early stage when they're small and localized, which is the whole point of screening, then they can be surgically removed for a cure. Okay. And in many cancers, many of the small, certain kinds of cancers, the rate of cure is extremely high. So that finding them is no longer a death sentence, as we used to think, but rather an opportunity to have a complete cure of cancer.
And see, that's an area where there's been a major study that has really changed the way we think about screening. For several decades, there were a number of studies looking at chest x-ray, recurring chest x-rays in high-risk patients, and none of them showed that we were picking up the cancers earlier or saving lives. But maybe you can say a few words, because we're running out of time, about that major study that has changed our thinking about screening for lung cancer.
Well, the major study looked at high-risk patients who had smoked for 30 pack years. That's a pack a day for 30 years, 2 packs for 15 years, between the ages of 50 and 74. And in that population, screening them was shown to decrease the likelihood of death from cancer by 20%. That's an effect much greater than we see with screening for breast cancer with mammography, or screening for colon cancer with colonoscopy. It's a very high impact intervention for a disease that is typically lethal if it's not caught early.
And I know that we at Norwalk Hospital initiated a screening program, I guess the first in the state of Connecticut, after that study was published, and we have Dr. Bauman joining us in the next segment to tell a little bit more about that screening program, to talk about the gold star that we received for our
He's one of the people who developed the screening program, and as you said, the first in the state, one of the early ones in the country. I think we all recognize the importance of this. As soon as the study was published, we knew this was high impact, very, very important to our community.
Common cancer, picking it up early, saving lives is a major impact on folks. So we're going to talk with Dr. Bauman when we come back a little bit more about screening and about the lung cancer program that's been set up at Norwalk Hospital. We'll be back after this short break.